second. I am going to set my timer for another 50 minutes so we can stretch our legs. We'll take just a 5-minute break next time, just so you guys can have a second to get some water. All right, so the purpose of periodontal charting, can you guys see that? I hope, if not, chime in, is to record baseline data, provide information necessary to establish a diagnosis. It's an aid for treatment planning, right? If somebody has 1, 2, and 3 millimeter pockets and their gingival margin, their gingival margin is right at the CEJ or that 1 millimeter coronal. You should have learned that in Miss Simmons' class, that the gingival margin at its healthiest point is actually 1 millimeter on the enamel and not always right at the CEJ. So if their pockets, if I'm taking my probe measurements and it's 1, 2, and 3 millimeters, I would say this patient's a 6-month appointment, right? And I'm talking about you guys, you're 1, 2, and 3 millimeters, really no recession to speak of, healthy. If we had x-rays to view with our probe readings, we would see the bone height was nice and stable where it should be, with a nice crest, and good height. So that is telling me how often you should be seen to maintain health. We know about every 6 months keeps people fairly healthy, so we stick with that schedule. Now, if I have a patient and I've probe charted, just probing, and I have 1, 2, and 3 millimeters, but I can see recession, and they have 5 millimeter recession, 6 millimeter recession here, there, and everywhere in their mouth, that bone used to cover that root, right? You should have learned that with Miss Simmons. Usually 1 to 2 millimeters below the attachment fibers is the crest of the bone, the alveolar ridge. So if I have 5 millimeters of root exposure where there used to be gingiva, there also used to be bone up there. So this patient has shown intense susceptibility to bone loss due to mechanical reasons. Maybe a hard toothbrush with aggressive scrubbing has slowly eroded away the protective gingiva and bone structure, is in response to that irritation is resorbed as well. Or they have gum disease in their past. You never cure periodontal disease. So just because their pocket depths are 1, 2, and 3 millimeters like you guys have, the presence of recession is, past bone loss due to some type, usually it's a bacterial infection, slow chronic disease. They are no longer ideally 6 months. They're 3 or 4 and must be monitored regularly because they're not as healthy as you. If you had 6 millimeters and 5 millimeters of recession on the fronts and backs of all of your teeth, you would not feel like you were as healthy as you were with the gingiva and bone support you have now. We know this to be true. So you can't just look at probe depths and say this patient is healthy. Yes, they're healthier than if they have 5 or 6 millimeter pockets, but the probing with the level of bone support present needs to be the whole picture of how likely they are to maintain that health, because they've already shown that there is bone loss in their past. They will be susceptible to that for the rest of their life, and they need more detailed treatment, more frequent intervention, more frequent monitoring to maintain the level of health they are at this point. Okay, so that's what periodontal charting does. It gives us the whole picture along with x-rays to help assess patients' health. And we need to know, is it changing? Right? It's not just how often should we see this patient. We can always compare our probe depths and our perio charting for those patients who need a perio chart every couple, every time we do it, we'll compare it to the previous one and then maybe the one 4 or 5 years ago. Is there change? Is it getting, pockets were 5 millimeters before, now they're 3, that's a change for the better. But what is the clinical attachment level? And that's all of this data we're collecting gets us to a clinical attachment level that we compare year to year to help people understand if they're stable or if their condition is getting worse, localized or generalized. So those are the things we'll be talking about. It's also a legal document. If a patient says, I lost this tooth due to bone loss and nobody ever told me, but you have completed all this periodontal documentation and x-rays, and in your chart, you documented the bone loss discussed with patient has increased from this to this, right? From, 5 millimeter CALs to, to 7 millimeter CALs. There's a concern. We recommend every 3 months. We refer to a periodontist. All this documentation, along with this charting, the patient doesn't have a leg to stand on. They've been told they weren't listening. Okay, these are reasons it's also used for legal documentation and forensic dentistry. If somebody has passed away and their chart, they're unidentifiable, and their chart says that they think this patient is, they're saying, oh, could be so-and-so, right? And that patient 4 months ago at their dental appointment had an alveolar crest that was at the ideal level and fully interproximal peaks at the ideal level, and the patient they're examining has an alveolar crest that's 4 millimeters down the root, they know to keep looking, right? That's not the same patient. These are for unidentifiable patients and identifiable reasons, like a plane crash or this, that, or the other. So it's also, everything we document is used for that, especially x-rays. Okay. So it can be done manually. It can be done by a computer. You don't need to know more than that. We're investing our time and efforts in manual documentation. You read the number, you say the number's written, either in a computer document or on paper. For us, it's on paper. But the computer assisted, actually, you can tap on different buttons to mean 2 millimeters, 4 millimeters, or you can speak into a little microphone and it documents it for you. Very few offices have that. Just know it's a thing. You're going to see salespeople who, who have those types of things available. And when you get into practice, you can check into them more. We're not going to quiz you on computer-assisted probing programs. So we use our probe depths, which are learning how to measure probe readings of the sulcus, right? Or period pocket, if it's 4 millimeters or greater, we no longer call it a sulcus. We also will use our x-rays to assess missing teeth, because before you can chart, you need to know what tooth is in the mouth and what can happen if somebody has a 6-year molar, right? Number 3, number 14, number 19, or number 30 removed when they're 6 or 7 years old because of decay or fracture, usually it's decay, then that patient second molar, because the first adult molar, permanent molar, was extracted when they were so young, sometimes the second molar will shift into the first molar position. And you will need an x-ray to see what's going on, because remember from the Simmons class, first molars and second molars have subtly different anatomy, slightly different root structures. And what else you can see in an x-ray is the crown of the tooth has moved into, say, number 30 position. Number 31 is drifted forward into number 30. But what you'll see a lot of times is the roots are still kind of angled backwards. They're not straight under the tooth like if it had erupted in that place and not drifted into position. So from an x-ray, you can kind of see the roots aren't right under the tooth. They're kind of still over where the tooth originally erupted, you know. So those are things we pull together to say, okay, on our probe chart, we need to cross out number 30 because that tooth is number 31. It's just drifted forward to fill that void. That doesn't happen as much in adult, like, you know, over 25 or 30 when a tooth's extracted. It'll drift some, but not fully into a molar spot. But, you know, when it's extracted young, it could. And it could be very hard to tell which tooth is present or not present. So our radiographs, there could be impacted tooth. Where is that canine, right? Like, oh my gosh, was it extracted? And a lot of patients will be like, I don't know. Sometimes they do know, but many times they don't, or they think they know, but an x-ray tells a different story. We can see open contacts. We can see bone levels and defects, right? A horizontal bone loss, that tissue will tighten down with aggressive treatment if there's disease present to become more shallow, healthier depth, hopefully, right? With their good home care. It depends on them a lot too. But if there is a vertical bony defect, those fibers are not going to want to go down healthier to fill in the void of that vertical defect, even with aggressive treatment. A lot of times you'll need periodontal surgery and bony implants and things like that to fix that type. So knowing what kind of defect you're trying to, you know, to work with to get a better health, to get a better response, gingival response of health after quadrant scalings, which is 4 appointments to scale a patient's mouth, 1 quadrant at a time to remove deposit. And that's usually what they do in a periodontal office. They'll focus just on 1/4 of the mouth, get it as healthy as possible to, you know, and in dental offices too, you can do that. So, but you would anticipate you're going to get a different response from a horizontal bone loss than you are vertical bone loss. So those are things you're going to learn with your radiographs. Radiographs are not the most reliable means of detecting perio pockets. They can give you an idea of what's going on, but you cannot see soft tissue in your radiograph. So you don't know if there's a 6 millimeter pocket due to gingival overgrowth, due to swelling, due to, you know, like a hypoplasia from medications where the tissues get fibrotic and grow up the crown of the tooth or down the crown of the tooth for top teeth. So radiographs gives you one part of the picture, but not the whole picture. Study models, it's, you know, just something for your information. I'm not going to go into what they tell, the story they tell you. So this is the periodontal chart you worked with yesterday, figuring out where you put your pocket depths. The next line is gingival margin. That is measuring recession, which is easy, right? It's easy to measure recession. If there's root exposure, you measure how much root you see with the probe. So from the enamel to the gingival margin, you're measuring the cementum that's exposed. And you may do 3 measurements, just like probing. The CALs are where you take the pocket depth plus recession, because they're combined together to tell the story of how much support is around the tooth. If a patient has overgrowth, you're going to subtract that, and we're going to see that further down in this PowerPoint. So CALs are clinical attachment levels. These are the critical numbers that tell us the story of the patient's bony support and tissue, how shallow the pockets are, you know, which is what we want. That holds less bacteria, less chance for infection. MGJ, we're going to review again in depth in clinic tomorrow. So we're looking at the teeth and the periodontium. So teeth, we need to know how many, what teeth are missing, which I just referred to. Could be drifting going on. We need to know what teeth to X out on our chart, because we don't just go 2, 2, 3, 2, 2, measure, measure, measure. And you start at tooth number 1, just filling in the blocks, because you might get to tooth number 12 and have no more teeth to measure, right? If you were doing my mouth, you would have to X out all my third molars. You would have to put an X over the blocks for all of my first premolars, because for ortho, I had all my first premolars had to be extracted. So, you need to do missing teeth first. Sometimes they're unerupted. Occasionally there's a space filled with a primary tooth because there is an unerupted tooth underneath. Drifted, right? We talked about that. Malposed, extruded. So if a patient is missing number 30, number 3 above that tooth isn't getting constant exercise. So it will, the fibers will get a little lax and the tooth will start to drift down out of the arch lower than the other teeth. That's called extruded. So we'll see that a little bit later. Impacted, right? We're used to the word impacted because most people have third molars that are impacted. They never are able to come up out of the gum tissue or out of the bone through the gum tissue because there's the position that they are in, or, doesn't give them room to come down. A very, very few people have an extra tooth, and we need to know that before we chart. And these are the other things we're going to be talking about: wear, contacts, mobility. So you would black out missing teeth. If the crown is replaced with a pontic. So what is a pontic? A patient has, let's see if I have one on here. No, I don't. So if a patient has a missing tooth, number 30 is missing, you can fill that void with an implant, right? Put an artificial post in there to put an artificial crown on after, and it's done through surgery to insert the post in the bone. But the other way you can do that is to put a crown on number 29 and a crown on number 31 and suspend a crown to fill the space. So when the patient smiles, when they, they talk, there are 3 little crowns, 29, 30, 31, just like you would expect to see. But 30, when we go in to explore and look and take x-rays, there isn't any root under it. It's just a crown suspended between 2 crowns on either side that are on roots. So it's called a 3-unit bridge. There's a bridge suspended between 3 crowns and they're all fused together near the occlusal. So you could not floss down between the number 30 mesial on 29 or 30 distal between 31 because it's fused near the top of the crown. You would have to thread under that and clean under that suspended bridge tooth. So that's what it's talking about when it says pontic. Unerupted teeth. Let me see if I can go full screen. This is driving me crazy. Sometimes I can't forward. So this is showing unerupted teeth on number 1. Number 2 is showing partially erupted. So this tooth, you can see a little bit of the crown, but not all of it. So this happened to me with my third molars. If you had seen me just prior to my wisdom teeth, my third molars being extracted, I would have this oval here, but it would have been further down because you could just barely see the occlusal part of the tooth and maybe 1 or 2 millimeters down the buccal and lingual crown, but no more. The rest of the enamel was subgingival. You know, they just wasn't enough room to fully erupt into my mouth. So they had to be extracted, you know, because they decayed almost right away. Within a year, they decayed because I couldn't get to them to brush the occlusal surfaces. There were little tiny decay spots, but in my defense, but they did decay. So it happens to us all. So that there's not just unerupted, but partially erupted. Okay. So you would circle the part of the crown that you can no longer see, or that you can't see because it didn't erupt fully into the mouth. All right. So Hannah, are you with me there?
Yeah, I'm here.
Okay, let me know if this screen changes for you. Did you see that change to say drifted teeth?
No.
I hate that. Okay, thank you. Let me escape. I'll have to go back to this view. So drifted teeth is what we talked about. A tooth can drift into a space where a tooth has been extracted. And, you know, it's just that simple. What this is showing was number 20 was extracted, or I'm sorry, excuse me, this isn't lined up with the tooth number above it. Number 19 was extracted, and number 18 and 21 have drifted into the space. 18 and 20. This picture's just throwing me totally off, so I'm sure it's not helping you guys either. I need to move those numbers over. Okay, 19 is extracted, so they colored it all in black. And in the box, you would actually X it out so that you don't put numbers in there by mistake. So you'd put a little X across 19. And 18 and 21 have arrows pointing towards the space because that's the way the teeth have drifted, that, you know, into that space. See the curved line on 20? That is telling the story that the tooth has turned slightly. So the mesial, the buccal cusp, and the lingual cusp are now slightly twisted in a mesio and distal twist. And we'll see more pictures of that later on. When you're actually working on each other, if we see some of these things in your mouths, which everybody has a little bit of a version, a tooth version going on, we'll try to point those out on patients because it'll make it clearer for you to understand what these lines mean. So 22 is buccoverted. So the tip of the tooth, the incisal edge of the tooth is where the tail is, and it's pulling outward to show that it's going forward. Number 24, the tail is at the cervical margin and the point is pointing up to show the tooth is tipped backwards. So when you do your perio charting assignment, just prior to that, you're going to view a PowerPoint of the perio charting, you know, how to diagnose with your arrows on your chart, not diagnose, but define what's going on. This is what you're going to be looking at. You'll have a list. It'll say number 18, you know, linguoverted. Well, then you go to this chart to figure out what linguoverted is. So this picture's explaining mesiodrift and distal drift. This is a picture of malposed teeth. We all have a little tooth that tips or turns, maybe not this severely, but slightly. There's some diastemas, right, between this mandibular incisor. Diastemas are the spaces between the teeth. Just pick that up and slam it down or answer it. Okay, so buccoversion, labioversion. Hold on one sec. Okay, sorry about that. So malpose teeth, you have buccoversion, labioversion, which means the tooth is tipped slightly out of ideal alignment or slightly towards the tongue side or the palate. Just even slightly, we would note. Torsoversion is when the tooth is rotated. So if we go back to this picture and we call this canine 22, right? So it looks like 23 is slightly linguoverted. 24 looks like it's torso, right? The mesial aspect looks like it's tipped out slightly. 25 is definitely linguoverted, correct? 26 looks like it's probably in fairly good alignment. We'd leave him alone. And except they seem to be super erupted if you look at how tall they are compared to the canines. So we would have some little boxes above them, and we'll look at that further down our guide here, that shows that they're super erupted. So that's just what these definitions on paper, if you were to look at a paper chart with all of its little lines and curvy lines and arrows going forward, arrows going back, you could look at that. And before you even looked in the patient's mouth, because you review your charts before your patient comes in, you would know exactly what's going on in that patient's mouth without even having to see. You would know there's some crowding and some torsoversion and some buccoversion, linguoversions, some super eruption. So here's our extruded teeth. Number 14 and 17, which I can't see because this thing being small. So you mark it with an X, a little rectangular half box above or below the occlusal surface. Also document wear facets. So can you see on the chart number 23 and number 21 is blackened out the part of the enamel that's no longer there because it has been worn away. So we need to know that because traumatic forces can affect bone support. It can get worse over time. And we're going to see some pictures of that. And we need to document that. It's our job to document this patient's history from the time we see them in the office until the time they leave our office for whatever reason. So we need, they move or whatnot, their chart goes with them. So the next dentist can pick up where we've left off. But we need to document because sometimes people have slight wear and then they come in and, we see them, and we get used to seeing this wear, but without noting that just maybe 2 years ago it was slight and now it's moderate. And we'll talk later on how you tell the difference. You need to know this because my goodness, that's pretty significant if this patient is under 40. Now, if you have a 90-year-old with moderate wear, you're like, well, these teeth have been used. Like, thank goodness you had all these teeth to chew and eat. So the younger the patient and the more significant the wear, the more there's a concern. Maybe they need a night guard or, some other intervention because it's only going to get worse. It's already shown it's getting worse. But you don't know that if you don't have a history. So that's what this chart does for you. Open contacts, there are diastemas, right? You've seen people with 8 and 9, they have that little space there. That's like a classic diastema, where the contacts don't touch. That's all we're showing with these 2 lines. See the 2 little lines? Kind of hard to see on the facial on 9, but you would put 2 little lines to show that there is a diastema. This is how you would note furcation involvement. We'll get into furcations later. You just need to know that they can just barely be a little swoop. The little trunk of the tooth is starting to get that fossa, and that fossa collects more bacteria than a flat root. So we note that, so we know that's a trouble spot where this patient could get disease progression more quickly. And then there's classes after that. So this class 1 is that little trunk swoop. You can start to feel the dip. Their toothbrush bristles aren't going to get subgingival into that little fossa. We have to clean it out. Excuse me. Sorry. So, you
Bless
know,
you.
oh, thank you. Allergy season. So, you know, the fossas, we need to be reviewing our charts before our patient comes in because we don't want to miss scaling that fossa, you know, to keep it as healthy as possible. Because the longer bacteria sits, the more it just brews and gets more acidic and invites more aggressive bacteria to live in that acidic environment. And it gets more and more, you know, detrimental to the health of the tissue. So if you don't debride that for the patient, you could be the reason it gets worse, because maybe it would have stayed stable forever and ever if you had just cleaned that out for them regularly. Same with the little fossa on 5 mesial and 12 mesial. That's why we need to know to look for those fossas. Sometimes they're very close to the CEJ, and it takes very little fiber loss to expose that beginning part of the fossa. It's our job to clean that out. If we don't, and we don't assess it, know it's there, and we ignore it, we just do our little boop, boop, boop with our Explorer and a little fluff and puff with our, you know, anterior, lower anterior scaler, a little polish, you have allowed that patient to break down health-wise, because your job is not to be an assistant and remove supragingival debris that anybody could remove. Right? I mean, you don't need much education to chop away at a little super calculus and polish. Your job is to assess these weak areas and help the patient maintain them, and discuss with them with the patient why you're concerned about this area and why maybe we're going to see you more frequently to maintain them. So, you know, you have to understand all the reasons we do this charting.